in order to preserve the communicant vessels between the mucosa and the submucosa, they just anastomose healthy mucosa together and they pass the structured part dorsally with a buccal graft. So they have a reasonably good success rate at a follow-up of around 1 year. And this surgery, they claim it should be done only for strictures which are under 1 centimeter. If the stricture is more than 1.5 centimeter, it will lead to bulging of this urethra. So, to summarize the treatment of bulbar urethral strictures, if there is a history of straddle injury, if it is a traumatic stricture, excision and end-to-end anastomosis. For strictures which are obliterative but not traumatic, you have 4 options. Do a double face. I still prefer doing augmented anastomotic urethroplasty somehow. We have options of doing non-transected anastomotic urethroplasty. I think Dr. Imran has a very good series of doing a non-transected anastomotic urethroplasty. We have augmented non-transected anastomotic urethroplasty as described by Welk and Kodama. And while doing these strictures, non-traumatic obliterative strictures, it is always safe to make a urethrotomy dorsally, okay, and distal to the strictured part, so that you can know what to do. Don't just go and divide the urethra. In case of non-traumatic, non-obliterative bulbar urethral strictures, we have an option of doing dorsal only if the stricture is long, or if the stricture is located in the distal bulb, and we have an option of doing a ventral only if it is proximal and middle bulbar urethra, and it is always to be done. Ventral only is always to be done in case of post-URP proximal bulbar urethral strictures. So this ends the talk on bulbar urethral strictures. Now let's talk something about the penile urethral strictures. So why is penile urethral stricture different from bulbar urethral stricture? As we discussed, it is surrounded by the thinnest part of corpus spongiosum. There is a very thin layer of corpus spongiosum. So the only option which we have is dorsal onlay or an inlay. The strictures tend to be longer. Most of the strictures are inflammatory. We cannot perform an excision and end-to-end anastomosis. So the only options which you have are either augmentation or substitution. And the success rate in general compared to bulbar urethral stricture is less. So etiologies I discussed previously in the earlier slide. Most of the strictures are because of lichen sclerosus or iatrogenic, but there is a growing number of patients who have penile urethral stricture as a result of failed hypospadias repair. So augmentation using either grafts or flaps is the mainstay of treatment for penile urethral strictures. There is no role of DBI or UD. UD is just palliative. Anastomotic urethroplasty is not recommended for penile urethral strictures because it would lead to penile shortening or cordy. However, the Egyptian group, the team of El Kasabi, has described augmented anastomotic urethroplasty with the ventral Orandi flap in strictures which are very short. They are called it mini stricture, strictures which are less than 1 centimeter. And in case of very severe defects, in case of very severe strictures, some patients are happy with a perineal urethrostomy as well. This has to be kept in mind. And tubed grafts or flaps are not recommended because these are associated with very high failure rate. So grafts. So when do we use grafts for the treatment of penile urethral strictures? It is used for single stage repair of non-obliterative strictures. Non-obliterative meaning the urethral diameter is more than 6 French, and for stage repair of obliterative strictures. Again, the graft material could be oral mucosal graft or inner prepuce or penile skin. So oral mucosa has been compared with the oral mucosal graft has been compared with skin graft. There is a higher success rate associated with buccal mucosal graft. So buccal mucosal graft is universally more popular. So graft placement can be done only dorsally. It can be done as an onlay or it can be done as an inlay. The Osopa technique.
Can you hear me?
Onlay is not recommended because
I need.
Hello?
Yeah.
Yes?
I need to restart this because this meeting will end in less than 1 minute. So we need to restart this meeting because of the scheduled time was 40 minutes. So we will restart it and we'll ask you to rejoin again and continue.
Okay.